Good day, everyone. I'm Dr. SREELAKSHMI, Senior Lecturer, Department of Pedodontics and Preventive Dentistry. Today, the session is on the topic chemomechanical caries removal. Chemomechanical caries removal. What do you mean by dental caries? Dental caries is nothing but a multifactorial disease which was characterized by the demineralization of the inorganic and destruction of the organic substance of the tooth. So, after dental caries have been affected by a tooth, earlier the traditional approach of the cavity preparation was proposed by J.V. Black, and it was for amalgam especially. And the main principle behind the cavity preparation was found to be extension for prevention. And now in this new era, it has been changed a lot. That is, minimal cavity preparation has been stressed more. So, apart from this traditional dentistry, by using of the sophisticated instruments, now we are in the era of a minimal invasive dentistry. So, what were the disadvantages which was faced by using the traditional approach of the dentistry? That's traditional cavity preparations. The perception by patients that drilling is very unpleasant, and the frequent use of local anesthesia and the pressure effects which was more by the usage of this aerator on the pulp, the pressure effects on the pulp, and the use of handpiece may result in the removal of softened but infected dentin, resulting in excessive loss of tooth structure. So the minimal invasive dentistry is as having a objective of using the least invasive surgical approach with the removal of minimal amount of healthy tissues. Healthy tissues is retained, and the minimal tooth structure which is being affected by caries has been removed, and mainly the cavity is being restored by using an adhesive material, so that the mechanical bond of the which was required by the amalgam was resulting in the loss of excessive tooth structure that was minimized. So the different MID techniques are air abrasions, ART, that is atraumatic respiratory techniques, sono abrasions, lasers, and another thing is the chemomechanical caries removal, which was proposed by Erickson in the year 1999. So, according to Banerjee et al., the definition of what do you mean by this CMCR or chemomechanical caries removal was, it's an effective alternative for caries removal because it brings together atraumatic characteristics and bactericidal or bacteriostatic actions. So basically, as I told, this is nothing but a non-invasive technique of caries removal by eliminating the infected dentin and preserving the affected dentin and healthy tissues, mainly by using a chemical agent, so that there is an avoidance of the pulpal irritation and also the patient discomfort to an extent. And materials being used after the CMCR has been applied on the tooth is being the adhesive material restoration, adhesive restorative materials, that is GIC and composites, which is bound to the dentin surface very nicely rather than the amalgam. So, what are the disadvantages of advantages of this chemomechanical caries removal? It's a less perception of pain and more comfortable for the patient. Less fear and anxiety to the method leads to less discomfort to patient. Especially, we can use this in children. Remove only infected layer and leads to more tissue preservation, and there is no pulpal irritations. And it has been well suited for the deciduous teeth and who is having a dental phobias and medically compromised patients, obviously. Better removal of caries in uncooperative patients. It can be used in physically handicapped patients, and also the patient who is having infectious diseases like TB, where there is a prevention of droplet infections. So the active ingredient in this gel or in this substance, the material which we use for the CMCR will usually soften the degraded collagen of the lesion and without causing any pain or undesirable effects on adjacent healthy tissues. Earlier, Habib et al. In 1975, he has used the sodium hypochlorite to remove the caries. The concentration he used was 5% of the sodium hypochlorite, and which was found to be toxic and aggressive to the adjacent healthy tissues. So the new solution was then prepared by using sodium hydroxide and glycine, which was added to this 5% of sodium hypochlorite. So chemomechanical caries removal agents are actually of two types. That is sodium hypochlorite. Initially, it was, as I told, 5% sodium hypochlorite was used initially by this Habib et al. And so this is having a two types of agent materials. That is sodium hypochlorite based and the enzyme based. Sodium hypochlorite based chemomechanical caries removal agents and the enzyme based. So see, sodium hypochlorite is nothing but Caridex and Carisol, and enzyme based is Pepacare. So the journey from GK 101, that is Caridex to Carisol. As I told Habib et al. In 1975, he has used 5% of sodium hypochlorite, and which was found to be aggressive to the adjacent healthy tissues. So initially it was GK 101. It was developed by adding the sodium hydroxide, sodium chloride, glycine to this 5% of sodium hypochlorite, and also it comprises of N-monochloroglycine. This was much effective than of hypochlorite, which was used alone. That is 5% rather than using 5% of hypochlorite alone. This mixture was found to be very well effective. But the disadvantages of using this agent was mainly the slow removal of caries, and cavity preparation was actually needed according to the Black's cavity design. And next it was GK101E, that is 101E, that is our Caridex. This in this, as I told, the sodium hydroxide, sodium chloride, and glycine was added to the 5% hypochlorite in the ZK101. Here, this glycine was replaced by aminobutyric acid, and the product being formed as N-monochloroaminobutyric acid, which is also designated as GK101E in 1975. So this composition is actually of two solutions. It consists of solution 1 is sodium hypochlorite, solution 2 is sodium chloride, aminobutyric acid, and sodium hydroxide. This was having a pH of 12. So what is the mechanism of action behind this GK101E or Caridex? There is a chlorination of the partially degraded collagen, and there was a conversion of hydroxyproline to pyrrole 2-carboxylic acid, which was initiated the disruption of the altered collagen fibers in caries. Thus, it facilitates the removal. So the delivery system. The delivery system is solution was applied to the caries lesion. It actually loosened the caries dentin by gently scraping action. Application continued until dentin remains seemed sound, and after 15 to 20 minutes treatment, only clinically sound dentin was remain in the cavity. But still, there are limitations for this. Rotary or hand instrument cannot be completely eliminated. Still, the usage of this has been usage of rotary instruments cannot be eliminated. Removal of enamel overlying caries, removal of existing restorations and for cavity designs when non-adhesive restorative materials are used. Slow procedure, as the time involved is around actually 10 to 15 minutes, and the costly as large volumes of solution were needed, because this was solution in nature. If you use a gel, means there's a minimal quantity only needed. So since it was a solution, a large volumes of solution is needed for a removal of caries. So then a CARIES was developed. CARIES was nothing but the sodium hypochlorite based only. It was developed by Fraser Hedwards and Lars Strait of Mediteam in collaboration with Jan Eriksson and Rolf Bornstein in Sweden in January 1998. The key difference of Caridex and Carisol is what? The use of 3 amino acids, that is lysine, leucine, and glutamic acid, was used instead of aminobutyric acid in the Carisol. So counteracted the aggressive behavior of sodium hypochlorite on the oral healthy tissues. So the composition is, it was available as a single mix or multi-mix syringes. Syringe 1 was containing 0.5%. Earlier it was 5% of sodium hypochlorite. Now in Carisol it was only 0.5%. Syringe 2, it contains 3 amino acids, that is glutamic acid, leucine, and lysine. And the gel substance is, this is actually in a gel form. So gel substance is was given by the constituent, that is carboxymethyl cellulose, and there was an adjuvant present, that is sodium chloride or sodium hydroxide, and the vehicle is saline solution. There was a coloring indicator present in this CARIES, which was a helping agent, that was red. The gel is actually available in two different packages, either a multi-mix or a single mix. And the pH of this caries solve is pH of 11. So how this K-disol will act? When the K-disol is mixed, the amino acids actually binds with the chlorine and forms chloramines at high pH. The softening effect of the K-dis tissue is a result of several reactions that act in concert to disrupt the fiber structure of the collagen. So actually, I told there are three amino acids present in the case of K-disol. That is leucine, lysine, and glutamic acid instead of amino butyric acid in the case of K-dedex. So the peptide chains of all proteins, including collagen, are made up of hydrophobic and hydrophobic patches. So each of these three chloramino acid derivatives in the K-disol electrostatically attracts one of these patches, which effectively bringing reactive power to the full length of the target, the collagen fiber, while minimizing the unwanted side reactions from the hypochlorite. So the formation of chloramines actually reduces the reactivity of the chlorine without altering its chemical subfunction. So the chemical result of this process is a breakdown of degraded collagen, characteristically which was found in the demineralized portion of K-Race lesion. So the porous nature of demineralized dentin allows the K-Race salt to penetrate into it. The unaffected collagen is actually more resistant to this degradation. But the framework of degraded collagen is found to be porous in nature, so it can be broken down and easily be scraped off. So what are the advantages? Three amino acids are used instead of the one. So there is an improved interaction with the degraded collagen. So as there is an improved interaction, there was an increase in efficacy found. K-disol, it is having a higher viscosity and application of higher concentrations of amino acids and sodium hypochlorite without increasing the total amount of fluid used, therefore reducing the total volume required. Does not need to be heated or applied through a pump mechanism. Thus, as I told, increased viscosity enhances precision placement. Overall stability is increased and also improves the shelf life. So this is the method of removing the caries after you apply a CMCR, because you need to have a instrument tip which is having a sharp edge but a blunt angle. They thus provide excellent depth control, and when the dentist scrapes away the caries dentin that has been softened by this caries gel. When you use a sharp angle or sharper cutting angles, means it can also remove the healthier dental tissues. When it is a worn out burrs or excavators with rounded cutting angles, means it's just slide over the surface and the scraping effect is actually being poor, and still more the caries will be infected dentin will be remaining over the tooth. So this is a pictorial representation of using a chemomechanical caries removal gel. It was initial in this picture A. You can see the cavity which is having a caries. So after that, the CM agent has been applied. The CMCR agent is being applied, and wait for 5 to 10 minutes. Actually, for caries, the time taken is much less than K-dedex. And after that, you can see in the picture F, the whole caries has been removed. That's the infected dentin has been removed, but still the healthy adjacent tissues is preserved. So there are certain instruments which is needed for the removal of this caries after the chemomechanical caries preparations, which is mainly classified depending upon the tips. That is instruments with permanent tips and instruments with interchangeable tips. So even if you found that even after usage of the hand instrument, still more caries are present, means you can use a power drive TM. This is a combined electronic instrument for power operated minimally invasive caries removal along with the caries salt, and for also endodontic treatment. It's actually selective and precise. It's remove only caries dentin. It's usually fast, simple, and effective or efficient, and it usually operates with high tissue control and at a low sound level. Useful for patients with dental phobia. This is a picture of the power drive TM. So this is a caries clinical procedure of caries removal with the use of a caries salt. So this is a comparison which is very important of Kdx and Kdisol. As I told, both are two solutions, and the solution one of Kdx is containing 1% of sodium hypochlorite, but in the case of Kdisol, it is only 0.5% of sodium hypochlorite. So the harsh effect of the hypochlorite on adjacent healthy tissues can be minimized by using this Kdisol. Solution 2 is in the case of Kdx, only one amino acid was present, that is amino butyric acid. Now it has been leucine, lysine, and glutamic acid along with the sodium hypochlorite and sodium chloride. There is also a dye present in the case of Kdisol, that is erythrocin, and the pH was found to be 12 and 11. The physical properties, actually, the Kdisol is having a jelly-like consistency because of carboxymethyl cellulose, and Kdx, it is liquid. And the volume needed, you can see it's much lesser in the case of Kdisol, 0.2 to 1 ml, and in the case of Kdx is 100 to 500 ml. Time required is also minimized because of the higher viscosity of Kdisol, that is 5 to 15 minutes, and the Kdx is 30 to 45 minutes. So next is Pepacare. It's an enzyme based. It was introduced in Brazil in 2003. The main components are papain, chloramine, and toluidine blue salts. Thickening vehicles together bactericide and bacteriostatic and anti-inflammatory characteristics. So usually prophylaxis is being needed by and after the by using a rubber cup and slurry of pumice, rinsing with a air water spray, or mainly by using a cotton pellet has been enough. And isolation of the target teeth must it has to be done. Isolation has to be done. It's a priority. It is a priority for using a CMCR. Next is application of the Pepacare, allowing the chemicals to settle for 30 to 40 seconds. Now, the papain will act by breaking the partially degraded collagens, and contribute to the degradation and elimination of the fibrin mantle. Removal of the softened carious dentin using the opposite side of the excavator and promoting a pendulum movement. Now, application of gel, if you found it necessary that still more caries have to be removed, you can apply it once more. So the vitreous aspect of the cavity appears when the cavity feels free from the caries. Next is rinsing, either with a water spray or by using a 0.12 or 1% of chlorhexidine. Then dry, then make a restoration with a suitable filling material. It is actually biocompatible. The advantages of Pepacare, its antibacterial properties, as I told. It is having an antibacteriostatic and bactericidal actions. No recommend foam and anesthesia. It preserves the healthy tissues. No smear layer formation. The gel actually combines an enzymatic treatment with antibacterial properties. So the ingredients are in, this is another thing, this is CARIES. So it is having endoprotein, chloramines and dye, papaya, mainly papaya extract, essential oils mainly from the plant source. Gelling agent is accurate percentage to give exact consistency to gel. It shows anti-inflammatory action. So this is a picture of a CARIES, and this is a video recorded by usage of this CMCR. As I told, isolation is needed. Now the gel has been applied. This is a brand, okay, Brix 3000. This is just not for promoting anything. So after this gel is being applied, you can still see if you still see a caries being present, you can use the next volume of gel if needed, if you found it necessary. Otherwise, just wipe it off dry and use a suitable adhesive material. So that's all for today. Thank you.